Good afternoon, everyone. Welcome. Thank you for joining us for the second installment of this virtual panel discussion. Today, we come together as a Sunnybrook community to discuss a complex and critical issue that affects us all, and that is, of course, COVID-19. Many of you on today attended the session 2 weeks ago, and I'm most pleased and to welcome you back. And for those of you who are new, welcome and thank you for attending as well. I'm John Delandrea. I have the honor and the privilege to serve as president and CEO of Sunnybrook's Foundation. I'd like to quickly introduce you to our panelists. Joining us are Dr. Andy Smith, Sunnybrook's president and chief executive officer, Dr. Robert Fowler, an epidemiologist and chief of the Torrey Trauma Program, Dr. Jeannie Callum, a clinician, researcher, and transfusion specialist here at Sunnybrook. So welcome all. We'll hear first from Andy about how our community has galvanized to support our hospital and how we're caring for some of the most vulnerable patients. And then we'll hear from Dr. Fowler and Dr. Callum about some tremendously exciting research in COVID-19 that Sunnybrook is helping to lead within Canada around the world. Andy will close the evening with a matter of, I think, utmost importance and certainly attracting a great deal of attention in the community, and that is how a place like Sunnybrook plans to gradually return its services to normal. Let me end my remarks with something that those of you who were on 2 weeks ago heard about, but it bears repeating. And we're here to celebrate our closest friends and supporters. Since the middle of March, more than 5,000 of you have helped to raise now north of $7 million for Sunnybrook's COVID-19 response. And this is a truly remarkable outpouring of community support for which we are incredibly grateful. And as you'll hear, over the course of this hour, your generosity has a direct impact on the research that could one day put a stop to this pandemic. So on behalf of all Sunnybrookers, as Andy loves to call them, thank you for your support and thank you for participating tonight. And with that, I will turn over the proceedings to my friend, the CEO of the hospital, Dr. Andy Smith.
Well, thank you very much, John, and thank you very much, everybody, for joining us this afternoon. Good afternoon. It's a real pleasure to be here speaking with you this evening, and also with Drs. Callum and Fowler. So let me start by echoing John's note of thanks to the community. I don't think anyone is surprised to know that this has been a long and winding road. The first COVID-19 case in Canada was diagnosed at Sunnybrook back on January the 25th, and it's been really quite a surreal journey since that time. And there is no question that the support we've had in so many ways from the community for our team, for our teams, has really been instrumental in the providing resiliency for the team and really being a signal importance for the success that we've had as a team. January 25th, that means we're into the 6th month now since this saga of COVID-19 has begun, and it's really been quite a journey. There's been, of course, issues around PPE and testing and making sure our teams are protected, and then making sure we have the capacity and the advanced treatments and the advanced ICU capacity to be able to take care of patients within the hospital. And we've been very successful in that regard. Been extraordinarily proud of the individuals, of the teams here at Sunnybrook, and how they've been able to take care of the people who count on us when it matters most. Now, as it turns out, and as folks know from following this in the media and otherwise, a great deal of the COVID-19 story has taken place inside the hospital, but an even bigger part of the challenge has been outside of the hospital. And I've been especially proud of our many healthcare workers, the doctors, the nurses, the whole variety of allied professionals that have played such a key role in supporting our partners in the healthcare system outside of the hospital, in community setting, in long-term care and retirement home settings, for example. And we've also, that's been a very difficult challenge, and very pleased as we are here toward the end of June, how together with partners, we've been able to get things under control to take care of patients that count on us so much. Now, of course, speaking of long-term care, I wanted to highlight today, just because the Veterans Center at Sunnybrook, Canada's largest veterans center, is such a central part of what we do at Sunnybrook. And a lot of people have been asking me, how have our vets done, our heroes that obviously are the utmost importance for us to provide excellent care. And we've done really quite well here locally, been relatively unscathed. I do note that early on during the COVID-19 saga, there was one 93-year-old veteran who developed COVID, and we were obviously very concerned for him. And he pulled through and just sort of made his way through and recovered uneventfully, which made many comment on the fact that the veterans, there's a lot of tough men and women in there, and they've been through a lot through their lifetime. I'm very delighted that he did so well. So right now, we're doing very well in the hospital. The volume of COVID in the community is decreasing. Knock wood, we're in a positive and heading in a positive direction. Anybody who tells you they know exactly where we're going to end up, I think I wouldn't overtrust too many prognostic outlooks. But forward we go, optimistic and with a terrific team. So I'm going to stop at this point and begin by introducing Dr. Fowler. So John introduced Dr. Fowler. He's an intensivist, and importantly is the program chief of our Tory trauma program here at Sunnybrook. And Rob, tell us a little bit about the work that you're leading in the hospital, but especially on the international scene, your involvement with the cutting edge research directed against COVID-19. Over to you, Rob.
Well, thanks very much, Andy, and thanks, John, and to everybody that's logged in to be part of the event tonight. I, as John said, work in the Tory trauma program here at Sunnybrook. I'm a critical care physician, and so that means that I work in the intensive care units at Sunnybrook for the most part. And over the last coming 6 months or so now, a lot of that work has been treating patients with COVID-19. Andy's mentioned a couple of them. And I guess just before sitting down here in our studio in the ground floor of Sunnybrook, I was up on the 4th floor in our COVID ICU, where we still have a number of patients admitted, and seeing one patient, in fact, for one of the things that I might talk about and share with you today. The reason I would say that I'm involved in the COVID-19 response at Sunnybrook and sitting here is probably having the misfortune of being on call one day in 2003, around about March or so, and I got a request from one of my colleagues to admit a patient from a nearby hospital who was suffering respiratory illness and looked as though they were pretty sick. And that patient had been in a family with a family member that had recently returned from Hong Kong. And that family, unfortunately, many of them suffered what we now know to be SARS. Some died, and that began the SARS outbreak here in Toronto at a number of our hospitals. And we were consumed, I would say, over the next sort of many months with a lot of patients that were ill, came into hospital, and unfortunately some patients that got sick inside the hospital during SARS. And that was a very difficult period clinically, a difficult period for families and patients, but it certainly taught us a lot about treating patients with severe viral respiratory infections. And one of the things that I think we were able to do, and Sunnybrook was one of the leading institutions really around the world, was to describe that experience to other people. and particularly so that other people might be prepared to treat patients and be prepared to treat patients safely within hospitals. And as we emerged from the SARS outbreak in Toronto, there were a lot of lessons learned, I think, collectively here and across the city and across the country, indeed around the world. And it didn't seem too long before another outbreak was upon us with H1N1 pandemic influenza in 2009-10. And again, Sunnybrook, particularly the clinical teams and clinical research teams, were out in front to help, I would say, guide a lot of the country in the experience with H1N1 and again, describe that in clinical research. That's carried forward through a lot of involvement that probably folks out there might not even appreciate through outbreaks in other parts of the world. And so I look to other coronavirus outbreaks that have happened in the Middle East, Middle Eastern respiratory syndrome. People have asked us for a lot of help, and I think we've been very helpful at describing and helping to design clinical research to figure out what treats people best and what doesn't. And even as far away as West Africa and Central Africa during Ebola virus outbreaks, a lot of expertise locally here in the hospital and in clinical research. And so when Jerome Lease, one of our infectious diseases doctors back in really the very first part of the new year, was aware that this was a circulating problem in some parts of the world, we began to mobilize a bit to both treat patients, keep our healthcare teams safe, but maybe as importantly, to try to do what we can to describe our experience here at Sunnybrook and to figure out how we might be able to test different therapies, different ways of treating people so that others around the country and indeed around the world may benefit from that. One of those initiatives that I might mention, if it's okay, is a clinical trial that Sunnybrook was really instrumental in helping to develop and lead. The WHO has taken on this trial and called it Solidarity, and it's up and running in about 60 to 70 countries right now. Many hundreds of hospitals and centers are participating, and we've enrolled many thousands of patients across the world looking at medications that have been available ahead of this outbreak, and then medications that are newly developed for COVID-19. And between this and one other trial, I would say it's pretty remarkable, in fact, considering our progress in past outbreaks, how quick we've been able to ramp up and learn from our patients and learn with our patients around medications that work or not. And I might highlight just a couple of them up front, and maybe there'll be time later to speak in more detail. Hydroxychloroquine, for example, is one medication that was very, very commonly talked about in the news. It had a lot of press, certainly in the United States. Some wonder about whether it might work in COVID-19, and a lot of people using it around the world without really much evidence. Over the last couple of weeks, this trial and one other has been able to demonstrate that, in fact, it doesn't work, and that we should really focus our energies elsewhere, and we should avoid using that medication. And that's, I would say, sort of a world first, and really has helped to guide the therapy for COVID-19. The other medication that over the last few weeks we've been able to get a sense that it really does work is a commonly available anti-inflammatory, a kind of a steroid called dexamethasone that we sometimes use for severe respiratory illness and infection in the hospital, but we're often uncertain if it helps or if there might be some side effects. And definitively, I would say within the last couple of weeks, looking at thousands of patients, we've been able to show that in patients that are the sickest with COVID-19, using this medication in about 10 patients will prevent at least one patient from dying. And that's a very large effect size when we think about the effects of medications around the world. So in a relatively short period of time, we've been able to, I would say, help describe the illness and also help investigate treatments that with the assistance from so many other countries around the world are making an early difference in the way we manage this illness. And I might pause there, Andy, and allow things to sort of move on, but I hope we have a chance to come back to some of these points.
Okay, well, thanks very much, Rob. We definitely have some questions that were submitted. We'll get to those in the Q&A. At this point, I'm going to go to Dr. Callum. So Dr. Jeannie Callum, already introduced by John. Dr. Callum is a clinician, researcher, and a transfusion specialist. So she has a national and international regard as a clinician in in that domain. But during COVID-19, Dr. Callum and her team have become especially well known for some clinical trial that we're going to hear about today that has really garnered a significant place on the world stage. And we're really keen to see how this clinical trial, again, playing out at multiple sites, what it teaches us about the treatment of COVID-19. So with that, Jeannie, I'll pass over to you to tell everyone a little bit more about yourself and tell us about the trial.
Okay, thanks very much for that introduction. So I have many roles here at Sunnybrook. Andy likes to get the most out of his doctors. So I'm a researcher, I'm a hematologist in our cancer center, and I'm a transfusion doc, and I have a role in controlling laboratory test requests by all of the doctors across Sunnybrook to keep healthcare costs down at Sunnybrook. So I certainly didn't see our Conquer-1 trial for COVID-19 patients coming. Over the month of end of February, early March, I was really focused just making sure that we had a safe and steady supply of blood coming to our patients at Sunnybrook and our other hospitals. We were really worried that the donors weren't going to come out to donate because they had fears about COVID-19. We'd had a few requests from some of Dr. Fowler's patients and their family members who were in critical care asking for convalescent plasma that they had read in newspapers were being used in other countries. But of course, we didn't have it in Canada. And really, that was the first start of that this was coming. And then around March 25th, the cases in Canada jumped from about 50 to 60 to 600 to 700 over a very short period of time. And that's when I got on the phone with one of my colleagues at McMaster, Donnie Arnold, who's a transfusion hematologist like me. And at that point, we realized we need to make this happen for Canadians. And that's when we started. We initially started with a English-speaking trial outside of Quebec. Not that we don't like our friends in Quebec, but they have a different language and a different blood supplier. But then we realized, no, this had to be a pan-Canadian trial. So over a weekend, we actually merged a convalescent plasma trial from Quebec with one from English-speaking Canada and took the best of both worlds to build this really fantastic protocol. And then to make things even more complicated, we got a contact from our friends in Manhattan to say they want to join the Conquer-1 trial, which of course we were very enthusiastic about. To make things even easier, their head of ID is a Canadian who trained at McGill. So we had no resistance there. So it built this phenomenal team to make this happen. For the first 3 to 4 weeks, we actually had 7 days a week, 2 conference calls a day, one at 8 o'clock in the morning, one at 6 o'clock at night. The first one to say, what's going to happen today? What's everybody doing? And this is about 30 people working 24/7 to make it happen. And then one at the end of it to say, did it get done? Okay, what are we doing tonight? What's going to be on the table for tomorrow morning? We did something in about 3 to 4 weeks that takes years to do, to launch a trial. So we're performing this Conquer-1 trial at 50 sites across North America. And we're going to be randomizing patients who are moderately sick with COVID-19 to either convalescent plasma or no convalescent plasma, and then we just watch them. Convalescent plasma is just the liquid part of the blood that we take off the blood donors that we use normally for patients that are, say, bleeding from a trauma. We use a lot of plasma in hospitals, so we know it's very, very safe. We're not just using any convalescent plasma donor with COVID-19. We're taking the 60% of people after they recover that have extremely high titers, very high levels of neutralizing antibody, which means in the lab, these antibodies protect cells from being invaded by the COVID-19 virus. We got tons of donors, 2,000 donors registered and came out to donate just with a social media call. We didn't have to contact public health. They just came out in droves. It was very heartwarming. So to do a trial like this takes hundreds and hundreds of people across the whole now North America. To do these trials is very expensive. And we couldn't have gotten started without the donors from that came through the Sunnybrook Foundation. And this was really the seed money that we used to give us the confidence to get started so that we were up and running by the time we were able to submit to the federal funders. And so when they got our grant, they could see these people are already up and running. They've got the confidence and the skills to do this trial. So really, I have no complete confidence that we would never have gotten to this far without the donors from Sunnybrook. Our first goal is just to figure out, does convalescent plasma work? But then our second goal is, if it works, really understanding with a lot of tests on the donor and the recipient, who makes the best donor and who's the recipient that's most likely to benefit from convalescent plasma. Sunnybrook's role in this is to do the logistics, really get into the weeds to help the sites across the country manage the trial, get their research ethics boards submitted, get all their people trained, get all their docs trained, make sure they understand how to collect the data and how to tightly adhere to the trial protocol. We have lots of people that we normally do trials in trauma and cardiac surgery, because that's what we do at Sunnybrook, but they've been repurposed, and really it's almost like they spent the last decade really training for this trial. So I think we've all started to realize that until we get a vaccine, we're going to continue to see patients with COVID-19 coming to our hospital, even despite the best efforts of everybody to social distance and our public health. But so in that intervening period till we have a vaccine, we've got to find some treatments that help bridge to that vaccine. But we can't be offering treatments without evidence. That's just bad medicine. And so again, I want to thank Sunnybrook Foundation for supporting this trial and all of the donors. We could never have gotten it launched without your help. This was really the seed that got it started.
That is terrific. So thank you, Jeannie, and thank you, Rob. And I've got a number of questions now in front of me, and I'm going to ask a few to you, Rob, and then go back to you, Jeannie, and then I've got a few more that I'll ask actually both of you to answer. So Rob, I know that you can't presuppose the end of a trial, and but having said that, as you reflect on the different antivirals and the combinations of antivirals that you spoke about earlier, if you were to say, where do you think the most promise lies? What's your hunch?
That's a great question. I think that what we often find with viral infections, and this is a bit different from, for instance, treating a bacterial infection with one antibiotic that we know works for a particular organism. Viral infections often benefit from treatment from a range of different drugs. And the purpose of the trial that I mentioned earlier, that we are helping in a number of countries around the world, is to find what those best combinations might be. And so early on, we've found, one, that hydroxychloroquine doesn't work. That's good. We can set that aside. Two, we found that an anti-inflammatory that is commonly available around the world, one we use at Sunnybrook all the time for other conditions, dexamethasone, does work for sick people. And the subsequent drugs that are being tested in this trial are ones that we have used in other conditions. One would be a medication called Kaletra that has been used for HIV care for a long time, very effective. And we're many thousands of patients in now to determining whether or not there's some benefit in COVID-19. Another that has been investigated and reported upon preliminarily in the United States from a trial out of the NIH called remdesivir has some promise. Seems like people may have resolution of their symptoms a little bit quicker when they're taking this antiviral, but the world is still a bit skeptical. And this trial that we're engaged in right now will help to answer, I would say, the true benefit and potential side effect ratio of this medication, and I think help people figure out how that fits in. If I look ahead over the next few months, other medications that will come into our trial include interferon, that has shown some promise in other coronavirus infections. We will also eventually, very much the way Jeannie described, antibodies in the immune system helping to mop up virus and to take care of it before it sort of sets in. There will be eventually, and perhaps even from Canadian sources, monoclonal antibodies that are generated directly to the virus that might, in a complementary way to Jeannie's description, help patients that have COVID-19. And so this trial is really about trying to find the best combinations, and similar to Jeannie's description, this trial is going to go on for a long time. And so we can benefit from folks' help and support for, I'm sure, the next year to longer.
Okay. Thanks very much, Rob. Now, both you and Jeannie pointed out that the treatments we're talking about are used in people that are sick, so moderately sick, or we're concerned that they're going to become very sick. And we all know that the majority of people that get COVID-19 get a milder version of the disease, and they're able to be monitored usually at home, and we expect the outcome to be good. So with that background, how can, or what have we learned through the months so far of COVID-19 about predicting who's going to get sick? What risk factors, whether it's age or other illnesses, have we learned predict who we are most worried about, or who you're the most worried about, and that may be requiring these advanced therapies?
Well, we at Sunnybrook, there's a team predominantly staffed by the Infectious Diseases Services, and they will follow patients in the community after a positive swab. They may not be sick enough to be into hospital, they may not need oxygen, but following them along and helping them figure out who might need to come into the hospital. Typically, because people will need oxygen support, and then perhaps because they get sicker and need more critical care. The sorts of things that I think get them concerned, and I think the risk factors that you speak about are ones that we have seen in a number of other viral infections and seem to play out in COVID-19. And so there's no question at all that the older we are, on average, the higher risk we're at. That's not for everybody, and you had a great example of our veteran of 93 years that got through COVID very well, but we know on average that age is a risk factor. Anything that conspires against the lungs and the lungs functioning optimally is a risk factor. Smoking would be a big one, no question. Chronic lung disease as well. And for reasons I would say they're a little bit less clear to most of us, there are often risk factors, including high blood pressure, cardiac disease, that seem to somehow together put people at a bit more risk. And so chronic comorbid conditions, not just those in the lung, and particular age, we kind of respect very much when we're following these patients as an outpatient.
Okay, thanks, Rob. We hear a lot nowadays about the idea of a second wave. It seems to me that around the world, some areas are experiencing a second wave or another bounce back in cases, and we don't know. For all we know, we may be facing a second wave sooner, or maybe it won't be until the fall. Maybe it'll be combined with flu. I think there's a lot of different permutations that may come to pass. But can you give us a little bit about what we're doing to prepare for a second wave, or what you think some of the key issues for you as an intensive care specialist are as we think about what a second wave might bring?
Yeah, it's a really good question. We certainly, through other outbreaks and this one, appreciate that the first hump of an outbreak curve, and in this case a pandemic curve, is usually not the last hump. During SARS, we breathed a sigh of relief after our first big wave of SARS, only to be hit with the second within about a month or so after. And that's the typical pattern, whether you look at influenza outbreaks, especially novel ones, or go down your list of viruses. And so we anticipate that. Why that happens probably has to do with a lot of factors. Some are very social, in that oftentimes people breathe a sigh of relief and then they come back together in close proximity, give the virus an opportunity to jump from person to person, infect new people, have transmission chains that we end up seeing in the hospital. I think for the first time in really modern history, perhaps since 1918, 1919 in the Canadian context, people have appreciated that this is the way that we can prevent others from getting infected. And that social distancing that I think was very effective in Canada, maybe a little bit less so in other parts of the world that happened to unfortunately start a little bit late or didn't have the jump on it, they really felt the brunt of the first wave. We only have to look as far south as New York State, New Jersey, and New York to see the mayhem that can happen in acute care systems if we relax that guard. And so looking ahead, I think we have all the tools right now to keep that second wave very small, but it's a message that people will be tired of hearing because we're all tired of this whole business with COVID, but it's a super important one to keep that second wave small.
Okay, Rob. Well, thanks very much. And that's sound advice. Jeannie, let me turn to you and with a few questions. You gave an excellent overview of how the plasma therapy might work. Can you speak a little bit about the history of this type of treatment? So what is the evidence that the plasma from a patient who has recovered from disease such as COVID-19 can be taken from one person and successfully given to treat another disease in another person?
So we actually have data that goes right back to 1918 with the Spanish flu, suggesting that patients who were very early after admission to hospital had better outcomes if they got convalescent plasma, but obviously in a time before, full randomized controlled trials. But even with COVID-19, I think we've had one good question answered for this. In the United States, over 20,000 Americans have been given convalescent plasma outside of a true randomized control trial. And we know that the adverse reaction rate is well less than 1%. So we know that the treatment is very safe, but we don't know yet if it's efficacious. There was one randomized control trial out of China of 100 patients where half of them got convalescent plasma and half of them didn't. And the patients that got it before they were on life support seemed to do much better. And so I think we're on the right track of targeting those moderately ill patients that are sick enough to be in hospital but aren't yet on life support. So I think we're on the right track.
So, Jeannie, you gave a great description of how many different investigators, how many different cities and across the continent got together to get this trial organized. So you've obviously had a chance to speak about patients where you see, oh, this looks like it's working. Walk us through what that looks like. So have you had stories of patients who are on the trial where they say, my goodness, you can just tell this is doing something positive?
Yeah, so I'm trying to be quite agnostic about whether or not convalescent plasma works or not in terms of looking at the data. Certainly, we have many, many patients who have gotten convalescent plasma, and we've been able to pretty promptly discharge them home, or they got to ICU and then we're right back out. So I'm optimistic, but pretty agnostic. We don't look in terms of any kind of efficacy until we have hundreds of patients enrolled in the trial. So we're going to have to be patient. It's going to be a bit before we have that first peek at the data.
Okay, patience has not been my strong suit. That's for sure. So we look forward to hearing that result. So help us understand what might an optimistic view. Let's say we end up having a positive result and it's got a clinically significant, impactful result. How do you think it would look for treatment approaches for teams across the world when treating patients later on in COVID-19 or maybe in future pandemics?
Yeah, so certainly in this pandemic, it would allow us to rapidly open up and start collecting from many, many donors and having it available to everybody across Canada. But also in other countries. The way that we collect plasma in Canada is with a special machine that's quite expensive. But, plasma can be collected from a whole blood donation. It can be done in every country. And so it's actually a therapy that you could offer in medium and low HDI countries. So I think it's very important that we answer this question, not just for high HDI countries, but for other countries as well. And for future pandemics, if it works for this, it means we always have to have a protocol for convalescent plasma stood up all the time and ready to go. We're not going to be able to wait 3 months to ramp it back up. We're going to have it ready to go, a donor collection program, a donor testing program, an inventory management ready to go. The other thing that is, I think, something that we have to figure out with this trial is matching the donor antibodies that we have frozen with the actual strain of the current virus that we have. We've already moved on and have had a bit of a mutation happen in SARS-CoV-2. And so we're now testing our antibodies that we have frozen. Does it work against this new variant compared to the first variant that was circulating in January? And so we're going to be chasing this virus, I know, for the next year and a half until we get this vaccine.
Okay, well, certainly a big challenge. So very much look forward to hearing the results of the trials that both of you are involved in. I'd like to now go to a couple of questions that I think might allow you to wax philosophic to a degree. And I'll ask you both on this. And let's go back to you, Rob. It really deals with collaboration. One of the things that you've both emphasized, and I have to tell you I'm extremely proud of, is that in our efforts to invent the future of healthcare, we realize that in the 21st century, you don't get there alone. It's a team sport. And both of you and your teams have really been exemplars of what it's like to lead, to collaborate, to work together to get to answers quickly, effectively, and accurately. So I wonder, Rob, just starting what you've learned here, and I know this is not the first time you've been involved on the international scene. Can you just talk about how you think COVID-19 has influenced the way we work together as a healthcare community, across the scientific community, across the continent and beyond?
Yeah, I think that's a great question. You know, I think if we look back to the way that a lot of science was approached, you know, maybe 50 or even fewer years ago, there was the notion that someone would come up with an idea. They would think about it locally at their desk. Maybe they would ask some colleagues. They would do some experiments in a lab down the hallway. They would toil at it for a while, figure out what works, what doesn't, and then they would, they would talk about their results, maybe small numbers of samples or small numbers of patients, and people would try to take that and make inferences about it. We know that, that's a great place to start, but it's not a great place to finish. And these days, very, very quickly, when something like this is upon us, you have a community that comes together with many of the same questions, and I think a much better appreciation that unless we work together from the get-go, that we're not going to be able to get to convincing answers quickly enough to help patients. And really within the first days to weeks of this new pandemic, in part, I would say, influenced and sort of taught to us by the experience with SARS and H1N1 and other viral infections, colleagues across not just the city, the country, but indeed the world will be working together on these sorts of things that have materialized into the clinical trials that Jeannie and I have talked about. And so, if we did a trial at Sunnybrook to try to answer the question about what medications work, and we, by good or bad luck, for instance, had to enroll 200 or 300 patients, we might get a sense of something that has some promise, but we'd never be able to tell patients with confidence that it works or not. But if we do that trial with our colleagues across the city, across the country, and in this case around the world, then a couple of months into the outbreak, we've randomized 15,000 patients in one trial and upwards of 5,000 in another. And you can look at the data in real time and say, we have a signal that statistically, clinically, we can believe in and try to feed that back to patients and families and other clinicians. So I think the collaboration has been terrific and also essential, and it's one that a lot of people here are leading the way on.
So it would be nice to have a time machine to try to understand, say, for example, the way collaboration can get us to answers in a relatively short time period now compared to, say, when the importance of insulin in treating diabetics, which of course was discovered in Toronto. Just give me a sense as to what you think the difference in the timelines are now in 2020 compared to, I guess, 100 or so years ago now.
Well, even going back, let's say 20 years, and that experience I highlighted with SARS, the world was relatively unprepared to deal with that. And the whole SARS outbreak unfolded, and when people look back, you go around the world and you're really unable to find convincing clinical evidence of a treatment effect for any medication, just not sort of up and running. And if you take the same number of months during COVID-19, you've come to a number of conclusions, not just sort of speculations or hunches, but real conclusions. And I'd say that's the tangible evidence that, remarkably, if you want, we've kind of learned from these experiences, certainly in the Canadian context, and we're much better prepared to get things going. And it's with the help of, certainly with the help of funders like CIHR, but frankly, so much support from the community at a grassroots level, those that, might view Sunnybrook as their home, other hospitals, their help has really made this happen.
That's great. So Jeannie, one of the things that's impressed me over the years, we think of Canada, there's millions of people live here, even more millions live across the continent and beyond. But when I think about you and the area that you are an expert in, it seems like the connection amongst the other top leaders in the country and around the continent is very, frankly, intimate. I mean, it's a phone call away, it's a text away. And even earlier, you're saying, I called up so-and-so and called up so-and-so, and this is how it went. What's that sort of collaborative or team sport at look like for you across the country and beyond when doing research like this and other things in your area of specialization?
So I think this trial has taught us that, maybe we can do trials a little bit faster, better than we did before. Normally when you do a trial is say, McMaster's running the trial, and then you have sites under McMaster and one site's running it. But, when we started this trial, we realized we couldn't do that. And so we had to kind of divide the running of the trial into multiple centers. So we have the University of Ottawa is running the distribution of the frozen plasma. We've got Hema-Quebec that's leading how to test the donor. We've got Canadian Blood Services that's figuring out how to doing neutralizing testing along with the lab in Winnipeg. Sunnybrook's doing the logistics, McMaster's doing the management of the data. New York provided amazing into the regulations and how to do this as a highly regulated trial. Normally it's all under one hat, and this we just disseminated out so that we could get it up and running so much faster. And not only just integrating within our own country, but also, Australia and Europe and the UK sent us draft protocols. We sent them ours, and we were, on conference calls saying, well, did you think about this outcome, or why are you excluding those patients? So we could really talk out very quickly how to lock down a protocol, but also harmonize them so that at some later point we can merge the patient data to then answer even bigger questions, making sure we're all collecting data in a very similar way so we can be merged at a later date. And it wasn't just the researchers that were all on board, but Health Canada and the FDA gave us 24-hour turnaround time on our protocol. That's unheard of. They jumped through hoops to help us get started. Canadian Blood Services were collecting donors within 3 weeks of us getting started. Really, the REBs gave us just rapid turnaround time. And it tells us that actually we can work faster if we're very collegial and work through it as a team rather than as an individual research group.
So here's a philosophical reflection, and I'm interested what you think about this. You don't have to delve too far into the daily newspaper to see many stories of whether for political or other reasons, things that polarize us as people across the country, across countries, and so forth. It sounds like what you're describing is precisely the opposite, and frankly, sounds quite heartwarming. Is that what it's like, sort of being inside this?
Oh, yeah. So everybody has been extremely collegial. There's now even a plan to put forward is to merging this data live instead of at the end of the trial, so that we can take data from Europe, from the UK, from Canada, Australia, merge it and answer that question even faster. Something we've actually never done before in transfusion. We wait till the trials are done, published, and then we merge them. And we're kind of rethinking, because of the pandemic and the need to answer this question to save lives faster, to do that live through the trial. So it's going to be a really interesting time.
Very heartwarming. Rob, here, let me ask you another question, and it's two-part. On the one hand, what are you most cautious about as you look to the weeks and months ahead? And at the same time, what are you the most hopeful about as you look ahead?
I would say the experience with SARS being a year in West Africa with the Ebola outbreak and seeing how these outbreaks unfold, I appreciate that working in the intensive care units can make a big difference for individual patients, but it's not the kind of thing that stops the outbreak. The thing that stops the outbreak is when you have change in public behavior to meet the outbreak on the street, if you want. And so the social distancing, wearing masks when we can't socially distance, that is a pain in the butt. It's the thing that will buy us time and prevent people from getting COVID and prevent people from, in small numbers, by proportion of everybody that gets infected, but it'll prevent people from coming into the intensive care unit. So I'm most cautious about relaxing that in our communities, and most cautious that if we slip a bit, that we will see the unfortunate effects of it about 2 to 3 weeks down the line. And so that's what I'd be most cautious about. All of this is to buy us time until we can get, hopefully, a vaccine that is pretty darn good. The thing that I'm most hopeful about is experience in other outbreaks that says getting a vaccine is not only possible, but it's possible in a relatively short period of time. Ebola has a vaccine now. Influenza has a vaccine that's tweaked every year that oftentimes works pretty darn good. And the other thing I'm hopeful about is that viral infections, I would say, over much of my training, and certainly up until the last few years, there was not a lot we could do about them. Medications didn't work that well. HIV showed us that with a lot of work dedicated to creating medications that work specifically on a particular kind of virus, it can work really, really well. We've seen the same thing with hepatitis C. We've seen the same thing with Ebola. And there are techniques that are going to let people discover virus treatments that we haven't even seen before for anything else work for this virus, and we just need some more time. So I'm really hopeful that we've got both a good shot at a vaccine and a good shot at treatments, but we need a bit more time.
Okay, great. Well, that's very promising indeed. So Dr. Callum, over to you. What are you the most cautious as you look into the viewfinder forward, and what gives you a sense of optimism?
So I'm trying to be really cautious about, what I read about new treatments, and being really cautious about making sure that those trials are done very rigorously and they're interpreted critically to make sure we're only offering to patients something that we know is going to work and it's not going to harm them. And we need to make sure that the trials that we're doing in Canada, even though we have to do them so quickly, we still have to do them with the same rigor that we've always done our clinical trials before. We're just going to have to work harder, work longer days to make sure that that happens. In terms of hope, I'm pretty certain that across the country, every researcher and every clinician is working very diligently to make sure every patient's getting the best possible care. And I think we see this happening already. Mortality rates are going down over time. So as people tweak their care, we're seeing better and better outcomes. And what I've seen in the Conquer One team, working so hard to make this happen and working so hard to communicate really well with patients. If everybody, I'm sure in public health, in ICUs, in COVID wards, in emergency departments are working just as hard as our team, it tells me that we're going to figure this out. And I hope that Canada, and with the help of the Sunnybrook Foundation, that we're going to provide major discoveries for COVID-19. And so I think we're going to figure this out. I think this disease is impacting us all in very different ways. And like you, I want to get back to normal. But normal, I don't think is going to come without a lot of hard work. And some of that hard work has come from the donors to the Sunnybrook Foundation.
Okay, well, let me close out with a bit of a personal question for you both. I know that we're all, everybody watching today, all of us, we're all people, all humans who've been deeply affected in many ways by this COVID-19 saga. It's been a grueling road. And we all do different things to sort of keep our shoulders back, chin up, and heading forward. I know that I've become obsessive about walking to and from work. That may be a little bit harder today, given that I think it may be still raining outside. But Jeannie, what's been the top sort of thing that's been great for you to keep you moving forward during this time?
Yeah, so one of my Conquer One research assistants, she's decided that we're going to do what's called a Grand Fondo cycling race of 160 kilometers. So she's got me doing hundreds of kilometers every weekend to get ready for that. So that means I'm certainly sleeping very, very well.
Very good. And Rob, what about you?
Oh, there's mixed blessings with this outbreak, that's for sure. I've spent more time in proximity to my son in the last 6 months than I probably have for the last 2 years. Most all of that is positive, I would say. We've gotten out on some great bike rides as well. But if I look ahead, like Jeannie, I'm hoping that we get back to a way that we can approach some of those other things that we haven't done for a while. And I mentioned to Jeannie before we started the call, I've got 3 hockey sticks in my back seat. I haven't been able to use them for 6 months, and I'm hoping to get out to an ice hockey rink pretty soon. I'm also hoping to be able to visit my parents in New Brunswick that seem to have done very well with keeping COVID at bay, but in part it's by not letting Ontarians into the province, I think. So we'll see if I can do that.
All right, well, good luck to us all. So before I hand back to John, I wanted to address a question that I get asked a lot. We get asked a lot in general at Sunnybrook, and it's not so much about the care of COVID-19, as important as that is and as central as it's been to our discussion this evening. It's about the knock-on effects that occur and the impact on non-COVID-19 patients. So everybody knows that since about the middle of March, across the world, across the country, across the province, and certainly across Toronto and in the patients that we serve at Sunnybrook, we have significantly reduced the ability for us to deliver care, for example, to cancer patients, to cardiac patients. Now, that has not been turned off, but it's been reduced, and that's been significant at a personal level. It's very difficult for patients who are already, for example, waiting for whether it's removal of a breast cancer or a PCI treatment to open up one of their coronary arteries, or a hip replacement so that they can get back to the business of moving around and living their best life. All of these things have been slowed down. So the key question in front of us is, how do we push that to get back to normal? And what I wanted to tell everybody tonight is that that is one of, in fact, arguably the central top priority on this day that's pushing us forward. We have we're blessed, as I said earlier, to have terrific people here at Sunnybrook. We've got terrific teams. And we've got a task force absolutely devoted to and driven to making sure that we've taken all the precautions, the testing, the PPE, all the physical distancing issues that need to be addressed to make sure that we can ramp up. That's the term we use, ramp up our care, for example, our surgical care, our procedural care, the ambulatory, the whole range of care. And in the last several weeks, we've been going up, 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 and up with that. I won't go through all of the results. One of I'm most heartened with was that last week was the first week that we did cancer surgery at a rate greater than 100% of the rate that had been in the same week last year. So when we're over 100% in an area, that's when we know we're on the right track. Now, that's cancer surgery. There's other surgeries that are still behind, but all boats are rising. All types of care are increasing in a staged, careful fashion, but with a relentless focus that we need to make sure that we're taking care of everybody. All of our patients with COVID-19, all of our patients with a wide range of ailments that count on us to be there for them when it matters most. So I really want to thank Rob and Jeannie. It's been fantastic chatting with you. And John, I'm going to pass the baton back over to you.
Great, thanks, Andy, and thank you very much for so ably guiding us through this last hour. And thank you, Rob and and Jeannie for your frontline insights to this. It's a great opportunity for the people who are on this call and on the previous one to begin to kind of navigate through all the information that's out there in the public domain, some of which seems in conflict with one another. So this has been just terrific. So for those of you who joined us, please keep your eye on your inbox. In the coming days, there'll be a link to a recorded version of a video of this session, should you wish to share it with others. We'll also be sending out a survey to get your insights on both of these virtual panel discussion events. I suspect that the future will have us doing more of these and having your critical comments. It will guide us as we go forward. I'd like also to just thank everyone again for the support of both Rob, Jeannie, and also Andy have alluded to just the fundamental value. And I think in many ways, it's not only the power of the dollars that are contributed, although those dollars are hugely valuable. What it also sends is an extraordinarily positive message to the staff, the clinicians, the scientists, the frontline staff, every one of the 10,000 people who work at Sunnybrook Health Sciences Center that says that the community cares about what you're doing. So thank you for joining us tonight, and be safe.